My name is Francesca. I graduated from medical school at AUB this year. My plan is to travel abroad in a few weeks, and today I'll be moderating your session. Our guest today is Dr. Fady Haddad. On a personal level, I am truly inspired by Dr. Haddad, but let me introduce him to everyone first. So, medical education at AUB. Before traveling to the US before doing his general surgery resident at AUB as well, and then traveling to Boston University for a fellowship in vascular and endovascular surgery, and then doing another fellowship in the Cleveland Clinic. He then returned to AUB and is currently the chairperson of vascular surgery at AUB as well. And today we'll be talking about carotid artery stenosis. So Dr. Haddad, the floor is yours. If you could share your screen with us, and we are really excited for this session.
Thank you, Francesca. Thank you very much for the nice introduction and for inviting me. It's a privilege to be, and I'm really excited to share with you the fascinating topic on which we have really extensive data, one of the most studied and looked at procedure in the vascular literature. So we're going to discuss today the extracranial carotid stenosis. Please let me know if we have any technical problem on this. Please stop me, and then we can adjust so we don't go further without having the screen being seen, or if you don't hear me well. We're gonna cover today extracranial carotid stenosis, a topic extensively studied in the vascular literature. We're gonna discuss an index case, a presentation. We're gonna talk about the stroke facts and the rationale about what we do and about preventing those strokes. And we're gonna look at overview of the major trials that dictated what we do today in the carotid stenosis, and we're going to go over some current guidelines in extracranial carotid stenosis. We're going to be looking at some specific scenarios in symptomatic patients and asymptomatic patients and patients in CABG or in carotid stenting, and also we're going to summarize it with an algorithm at the end. The session is expected to span all over, including question, roughly about 1 hour. And if there are any major or pressing, I'm going to hold a bit sometime in the middle. If there are pressing questions or you need to stop or repeat anything, please, I don't mind. Please let me know. So we're going to get started, and this is we had a 68-year-old gentleman, intensive, heavy smoker, that presented to our center with a history of 10 minutes loss of dexterity in the upper extremity, loss of motor function. This was not only subjective, because this was witnessed by his son at home, who confirmed that the patient not really grip on his left upper extremity. There was no other neurologic symptoms that were reported, like visual disturbances or loss of speech or consciousness or any of that sort. Upon arrival in the emergency room, the patient's relevant neurologic findings were indeed weakness still. Although the patient's report only a 10 minutes episode, he was still having, when he presented, weakness in the hand and all functions of the left hand, and he also had sensory deficit in the left upper extremity from the arm up to the hand. His hemodynamics were still. So overall, we are dealing here with a case of a new event that was in the 24 hours, and this was for all what we can say, and we're going to see in a bit, that it was a symptomatic carotid stenosis situation. The symptoms that can come from the carotid stenosis could be, first of all, no symptoms at all, patient presenting after a screening for some sort, or imaging of the neck for any other reason, or screening because of the presence of carotid bruits or perioperatively. Now, on the other hand, patient can present with a transient ischemic attack, which is labeled as a mini stroke or a focal neurologic deficit, which symptoms last in general for a few minutes up to an hour and can last up to but less than 24 hours, which is still in the of a transient ischemic attack. Those can be usually hemispheric or ocular in nature, like unilateral ocular blindness or amaurosis fugax. Alternatively, patient can present or can have established stroke, which is a neurologic deficit that have lasted for more than 24 hours. In general, this is a stroke even if the patient at the time of exam or presentation or enrollment in the trial have recovered completely from his stroke. An episode that has lasted for more than 24 hours, it is labeled as a symptomatic stroke for the sake of documentation. In the carotid studies and in the trial that we're going to look at in a moment, we're going to see that the patients were recruited and labeled as symptomatic in the trial if they had their symptoms for a certain period, depending on the trial, for around 3 to 6 months before the enrollment in the trial. So if a patient had a neurologic episode or a stroke or a TIA that happened beyond that period, for example, 1 year or 8 months prior, for the sake of the trials, those patients were considered to be asymptomatic in the trial that looked at carotid surgery. We use extensively for diagnosis the carotid duplex scan or a carotid ultrasound. Safe. It is a test that we repeated, very accurate and extensively studied and compared to the gold standard at that point, which was angiography in the carotid circulation. It can give a lot of information, particularly in regard to not only degree of stenosis, but also the quality of the plaque. So it's a good original initial test that most of the time is by a confirmatory test, be it MRA or a CT angiography. In particular, I would like you to look at the remaining patent lumen in that origin of the carotid artery with the hypoechoic, like the black surface that you can see around that area of stenosis, which is in a hypoechoic plaque in that particular situation. I put other contralateral side just to compare, and you see that this is a full circulating lumen with no evidence of plaque, at least on B mode image. We rely heavily on the velocity criteria to define the stenosis. And this was compared to angiography with the, and we know that when there is a circulating blood that crosses in a stenotic area of the vessel, you have an increase in velocity, and that increase in velocity is proportional to the degree of stenosis in the vessel, and this is what we use mostly to define the range or degree of stenosis in the carotid circulation. Very few people still operate on carotid stenosis, specifically in symptomatic cases based only on the carotid duplex scan. And most of the time in symptomatic, you couple that or confirm with a imaging modality, CT or MRA. Basically, you need to make sure that the patient does not have any other cause for his symptoms, for example, brain tumor, cerebral aneurysms, intracerebral vascular that could be the cause of the symptoms. This is the CT angiography of that particular patient who presented with the right hemispheric symptoms and the left body ischemic attack. And you can see here I put this as a global view of the carotid circulation. You can see both common carotids on the side dividing with a normal or minimal disease carotid bifurcation and continue the cranial carotid artery. And you could see on the ipsilateral side, on the right side, a severe tight stenosis on the origin of the internal carotid artery, which I magnified here for the illustration. Is a really very tight stenosis on that reconstruction on the right internal carotid artery. So this is what we do, and this is important to see. Most of you are familiar already with the carotid operation, but it is good to look at the specimen, and when you open that carotid and you look at the debris and the junk that is inside the vessel, or those floating particles that are ready to go with the bloodstream and cause a cerebral stroke, it is then and mostly then that you know that doing this procedure is doing a favor to this patient, and then it is worthwhile the risk of the procedure that we are taking versus the natural history. None of the preoperative image will really show you or give you that satisfaction that really this is the right thing that we're doing for that patient. More than that moment when you open the artery and you see that floating thrombus or debris or cholesterol debris that are sitting in plaque and red embolized. Now the question is, how do you do that procedure? There are many ways to do that procedure, provided you have consistent result commensurate with the acceptable result in the literature, and your result and outcome are reproducible. For example, we open the carotid longitudinally, although you can transect the internal carotid origin completely and do an eversion endarterectomy and then sew it back to the common carotid artery. We do a longitudinal standard open carotid endarterectomy where we scoop the plaque completely, and you can see here a hemorrhagic plaque, that one of the plaques that are prone to embolization. And then we close the artery also longitudinally, but using a patch to widen the arteriotomy while closing. And patch closure has been shown in the literature to reduce the incidence of restenosis and neurologic event compared to primary closure, whereby you just sew the artery primarily without widening it with the patch. Now, which patch material to use? We use still autogenous vein patch, but prosthetic patches or bioprosthetic like bovine pericardial work as well, and there are no difference in outcome in the literature between autogenous material and prosthetic patch material. There are few reported cases in the literature of infection of prosthetic carotid patch, and we have reported some of them. This is why we stick with vein patch in our practice, which is a bit more conservative, but overall in the literature, both are very acceptable ways to close the artery. The question that is going to be asked also is, what is this shunt or this tubular material that we use? This is a extra arterial shunt or bypass that we use to protect the cerebral circulation while we have the carotid closed. Also, again, I go back to what I started with. There are so many ways to do it, and one of the ways is people do not use shunt at all and use only selective. Some people use selective shunting only when it is needed, while doing the procedure under local anesthesia and asking the patient to squeeze or monitor the neurologic function to decide if the patient needs shunting during endarterectomy. As long as your results are reproducible and consistent with the acceptable result for this procedure in the literature, you can do what in your hand provide the best outcome and best result for the patient. We, in general, use routine shunting for most of our patients. Overall, if you are a selective shunter, you put a shunt only when needed. You would need, in general, to shunt anywhere between 5 and 10% of the patients. Again, this is where the look at the cleaned intima from inside, and this is the layer of the media, and this is the transected end of the intima, and you can see the patch here being sewn in place after removing of the plaque. This is the patch closure step in the procedure. Some facts. Well, this is a huge financial and economic burden. Stroke still represents the second major cause of death in Europe, for example, and half of the patients that are survival of stroke will be dependent in some sort of their life regarding certain activities. So it is a big financial and social and economic burden on the society. Now, the etiology of stroke is not always the carotid circulation, and there are many, including intracranial small vessel disease, cardiac thromboembolism, and we have to know also that about 25% after thorough investigation will end up with no specific etiology for the stroke. We will be working on the 25% that are caused by the internal carotid artery and middle cerebral artery thromboembolism. And if we can impact that number of patients in reducing the incidence of stroke, that would be a great achievement. And this is what we do, and this is what we're going to discuss in a moment. Also in the US, at least around 40,000 strokes in the US are attributed to the extracranial carotid circulation. And the risk of having a recurrent stroke within the next 5 years on this patient is around 40% in the untreated patient. This is the magnitude of the population that we will be working on, and the rationale after behind treating and doing the carotid revascularization procedure when indicated. And we're going to see which population will really benefit from having their carotid operated or revascularized versus best medical therapy. Symptomatic carotid stenosis. There was two major landmark trials. One of them was done in Europe, the NASET trial, and the other in the North America, the NASET trial, and the other in Europe, the European Carotid Surgery trial. Both are multi-center randomized clinical trials. And what did they show? In brief, they confirmed that in the subset of population only that have severe carotid stenosis, carotid endarterectomy will be better concerning incidence of recurrent stroke compared to best medical therapy. What was the NASET trial? The NASET trial was a multi-center trial enrolling 50 centers with patients who had symptoms over the past 120 days. As we discussed originally, if a patient had a stroke, for example, 1 year ago, for this trial, he will be an asymptomatic patient and will not be included. Back then, the imaging, standard imaging was the angiography, and any patient who had an angiographic stenosis in the carotid more than 30% was enrolled, but then it was categorized between 30 to 69 and more than 70% stenosis. Enrollment in those trials, and we have to remember that those robust trials were done in the late 80s and 90s. So this is why we're going to discuss a bit what was best medical therapy in that time. So this trial started enrolling in 1988. However, in February of 1991, enrollment and randomization was stopped for the arm and subcategory of patient who had severe carotid stenosis in the range of more than 70% because it had reached an endpoint with significantly reducing the incidence of neurologic event in this subset of patients with severe carotid stenosis. And there was a peer-reviewed clinical alert that was launched back then by the National Institute of Neurologic Disorder, stopping the enrollment of severe disease because the outcome was significantly in favor of carotid endarterectomy. So in brief, the NASET study confirmed that patients with high-grade stenosis, more than 70%, had a neurologic event rate, stroke rate, ipsilateral to the stenosis of 9%, almost 1/3 of what happened with the people who had a best medical therapy and who had 26% of ipsilateral strokes over 2 years. Now, the trial did not stop enrolling for the subcategory of people who had moderate degree of stenosis, which means stenosis in 50 to 69%. In that particular population, over time and over a 5-year period, it was found that still within that category, there was a rather a significant benefit from doing a carotid endarterectomy versus best medical therapy. However, the benefit that we acquired in that range of population was less, and the difference range between the stroke rate between the best medical therapy and the endarterectomy, the benefit was smaller than in the subcategory of severe degree of stenosis. And we're going to see that in that category of moderate stenosis, there are some subcategory of patients who benefit from operating at a lesser degree of stenosis and some that would not. In particular, the follow-up studies on the moderate degree of stenosis, 50 to 69%, showed particularly that people who had stroke versus, for example, TIA, and hemispheric stroke versus, for example, ocular symptoms will do better and benefit more from an endarterectomy versus medical treatment. In addition, and mostly, gender difference in this subcategory with moderate stenosis, for some reason, the male gender benefit more from operating at a lower degree of stenosis versus the female counterpart. The female did not show any significant benefit when the threshold to operate on the carotid was lower to 50 to 69%, possibly because of the higher operative complications in female, maybe, and we hypothesize because of the smaller vessels and more technical problem during the procedure. This was also confirmed in the asymptomatic trials, as we're going to discuss in a moment. So, in a nutshell, the NASCET summary of the NASCET trial, in more than 70% stenosis, if we look at the screen, we have an impressive 65% relative risk reduction, and the number to treat will be 6. You need only to treat without complication 6 patients, and you'll be saving 1 stroke. On the other hand, operating on a moderate degree of stenosis, you have a lesser relative risk reduction from this procedure, and you will need to operate without complication on a 15 patient to be able to save 1 stroke, with no benefit at all on operating on symptomatic patients with less than 50% stenosis, with no difference between medical therapy and endarterectomy. So overall, in the moderate degree of stenosis, the long-term benefit from surgery versus medical treatment was more favorable in the male gender, in people who had stroke versus less neurologic event like TIAs, and for patients who had hemispheric symptoms, for example, in comparison to people who had ocular or retinal symptoms. The European trial counterpart, which was done at the same period of time, showed in parallel the same result, that people with severe stenosis would benefit better from endarterectomy. However, not in the early period, probably because in the European trial there was a higher perioperative morbidity and neurologic event. So the benefit of the endarterectomy was only significant after 2-3 years of randomization. But still, overall and over time, people who had more than 80% stenosis, which with the way the European had measured the degree of stenosis was equivalent to a 60% degree stenosis in the European trial, would benefit more from endarterectomy versus medical therapy alone, with a relative risk reduction of about 43%. Subsequently, and based on those robust trials, and still the largest that was done till date, comparing procedure versus medical therapy, the guidelines came as follows. And you can see that here we have strong recommendation with level 1A or level 1 recommendation and level A evidence. Carotid endarterectomy is recommended in patients reporting carotid territory symptoms within the preceding 6 months and who have severe carotid stenosis, provided the documented procedural death and stroke was in the acceptable range for those trials, which was less than 6%. Now, if we go to the second recommendation in the guideline, when you go to the moderate degree of stenosis, 50 to 69%, you're going to notice that here the recommendation is softer and the wording also is different. And we say here, patients should be considered for carotid endarterectomy and not reported. And the class of recommendation is now 2A here. But what is interesting also in those guidelines now, that people who are elderly and have more than 50% symptomatic stenosis would be better off with endarterectomy versus carotid artery stenting, and we're going to discuss that a bit in a while. And this is represented here in the guidelines. And why? Because it was noticed that originally when stenting was started, that it would be a less invasive procedure on people who are octogenarians or who are elderly, and those would do better with stenting versus endarterectomy. This was not the case, and it was actually found for many reasons that we will discuss, mainly severe tortuosity of the vessel, severe calcification of the vessel, that people who underwent, elderly who underwent stenting had higher neurologic event than those who had endarterectomy. And that's reflected with the recommendation class 1A in the guidelines. All right, so in brief, the guidelines for symptomatic carotid stenosis in patients with severe symptomatic carotid stenosis, endarterectomy is strongly recommended versus best medical therapy. However, the European guidelines are a bit softer in regard to patients with moderate degree of stenosis, to which they gave only a class 2 recommendation and a class 2B recommendation also for the carotid artery stenting, which is a higher degree of recommendation in the American Heart Association guidelines. What is interesting also and important is the timing of that endarterectomy. And looking back at the randomized clinical trials and looking at recent registry data as well, it is recommended nowadays that the golden period to benefit from that endarterectomy the most is to do those procedures within the first 2 weeks after the index event. If you wait longer, then you're running the risk of the patient having his recurrent stroke within that period of the 2 to 3 weeks after the index event. And this is the period where most of the recurrent events actually happen after a stroke related to carotid stenosis. If you're doing it at 1 month or 2 months, then you're most likely operating as if you're operating on an asymptomatic patient. Of course, you're going to have a less incidence of perioperative morbidity and mortality. However, you'll be missing out on saving all those strokes that happens within the first 2-3 weeks. So the golden period and the recommendation today is to operate early after an index event. By guidelines, is within the first 14 days, but in many stroke centers, it is recommended to do it earlier, even within the first 7 to 10 days of the index event. All right. If we shift a bit from our index case and we look at asymptomatic carotid stenosis. This is interesting here because still at this point and this day and time, there is still controversy on operating on asymptomatic people. Let's look at the data. There are also 2 major trials, the ACAS, North American Asymptomatic Atherosclerotic Study, and the asymptomatic carotid surgery trial done in Europe. Both of them showed that people who have more than 60% stenosis would benefit from endarterectomy versus best medical therapy. However, we need to look at the number closer. And here we can see that we're reducing from the risk over 5 years of having a neurologic event or a stroke by 11% in the medical arm versus that is reduced to 5.1% in the surgical arm. Well, if we look at that in that perspective, and we have a patient in front of us who's coming walking and talking, and we tell him, listen, you have a carotid stenosis, and I'm going to be able to reduce your risk of stroke in the coming 5 years by around 50%, the patient's going to tell you, what are we still doing here? Let's go to the operating room. But there is a different way to look at that. If you tell the patient that I'm going to be able to reduce any absolute risk reduction, if we look at that, your risk of stroke by 2% or so, a bit less than 2% per year to around 1% per year, the patients walking and talking came without any neurologic event and tell you, doc, we're going to take the risk of the procedure to reduce my risk of stroke by only so much. I mean, can't we do that by any other mean, by medical treatment, for example? I mean, this is really a small benefit. And the numbers also state that. And you have a risk, relative risk reduction about 53%. But here you will need to operate the number needed to treat of about 17 patients without any event to prevent one stroke. And this was even criticized because here you're preventing any stroke that could be even a minor stroke, whereby in the European, they also operating on asymptomatic carotid stenosis was slightly less popular because the number needed to treat to prevent one disabling stroke or fatal stroke after 5 years is around 40 patients. And this is not easy to achieve. So this is why looking at asymptomatic carotid stenosis, the risk benefit that we're taking to reduce a 1% per year stroke and to get the benefit only after a 5-year period, this is where one has to sit and look and individualize any asymptomatic carotid stenosis to make really the best decision for that patient, if that particular patient will benefit from an operation that has such a small degree of benefit. More so, if we look at the gender effect, for example, already we know by the ACAS and the ACST European trial that female within the asymptomatic subset of patients has less benefit from the male counterpart when operating on an endarterectomy on an asymptomatic patient. So if originally already from overall we have a very small benefit from operating on an asymptomatic stenosis, and we're reducing even further the benefit from operating on a female, then there's a question whether there is any benefit at all in operating on an asymptomatic female gender unless you have something else to offer that will put that patient on a higher risk of stroke if she or he is not operated. So the guidelines came with some recommendation. Give us a bit more to be able to justify operating with such a small benefit on an asymptomatic individual. For example, imaging that will put the patient at a higher risk for theoretically for another event. For example, a silent cerebral infarct, stenosis progression from 60 to 80%, for example, impaired cerebrovascular reserve from contralateral stenosis prior stroke, or for example, spontaneous embolization on transcranial Doppler. And there are other also indirect criteria that can put an asymptomatic patient at a higher risk of stenosis. So the guidelines came as following those trials. In an average risk patient with asymptomatic 60 to 99% stenosis, carotid endarterectomy should be considered. Here you see it is not should be recommended, but should be considered. And with a level of 2A evidence, if in addition, one or more imaging characteristic may be associated with a higher risk. and if the patient has more than 5 years life expectancy, and if you have a morbidity and mortality from in your hand, in your center, with your procedure of less than 3%. If all that is secured, then you are okay operating on an asymptomatic carotid stenosis, especially in female, which has less benefit, with a softer recommendation from the guidelines. How about particular situation in carotid stenosis whereby you have an associated CABG or heart revascularization to be done? Looking at the trials and at the registries, stage or synchronous carotid intervention in people who were discovered incidentally to have carotid stenosis, there is no role in operating on their carotid, except in situations with severe bilateral carotid stenosis or in situations of contralateral carotid occlusion. And even that comes with a soft 2B recommendation. In patients who are symptomatic, on the other hand, and needs a CABG or cardiac revascularization, then it's a different story. And then there is the operating synchronously or staged carotid and CABG is recommended in people who has more than 50% stenosis and are symptomatic from their carotid circulation. If patient is coming up for a non-cardiac major operation, then the guidelines are clear and recommend, not only does not recommend, but recommend against doing the carotid endarterectomy in preparation for those major operations, and suggest that the aspirin and the statin should be maintained perioperatively on this patient population with a class 3 evidence of no benefit from doing their carotids. Should we screen routinely? Subsequently, now that we know what we know, should we screen for asymptomatic carotid stenosis? Looking at the limited degree of benefit and the questionable and controversial operation on an asymptomatic carotid across the board, then screening for asymptomatic carotid stenosis, like for example, you would screen for abdominal aortic aneurysm, is not recommended. The question of carotid artery endarterectomy versus carotid artery stenting. And we should talk a couple of words on that before we start concluding. When the carotid artery stenting started, and many people started doing right and left, and with the trials that included patients with limited experience in carotid artery and cerebrovascular intervention. Some of those trials actually included patients who recruited 2 patients, 3 patients from one center, with very little experience. It was obvious that the Cochrane review came in favor of carotid endarterectomy in those early days of carotid trial. Until later, the CREST trial, which is the largest and more robust trial that compared carotid artery stenting versus endarterectomy, came along. We're going to briefly talk about that. This is, for example, a case of mine of severe carotid stenosis. He had remote history of Takayasu in remission, heavy smoker with on top atherosclerotic disease, bilateral carotid artery stenosis. And this particular patient, we elected to go for carotid artery stenting, and he did extremely well. So definitely there is a major role today in carotid artery stenting. After the CREST trial with the multi-center randomized trial, which showed as a primary outcome of combined MI, death, periprocedural, and ipsilateral stroke, showed no difference periprocedurally at 4 years comparing carotid artery stenting versus endarterectomy. However, if we separate those outcomes and we look, for example, at stroke only, which is the reason those procedures are done, you're going to see that periprocedurally and even sustained at 4 years, the results show a significantly higher number of strokes and neurologic events in people undergoing stenting versus surgical carotid endarterectomy. Now, that comes as a price as well, because that is balanced by a higher number of myocardial infarction in people who undergo carotid endarterectomy. So in major discussions and major meeting was come, what do you want to die from, a stroke or a myocardial infarction? This was not really exactly true, because the myocardial infarction included chemical and asymptomatic MI, which were screened for, whereby the patients were not screened, for example, for asymptomatic stroke on imaging. And we have no idea about the long-term outcome of these minor MIs, whether that really affect the patient's life on the long run. So overall, we can say there are a bit of a higher, smaller neurologic event in stenting versus endarterectomy. But overall, if we lump all outcome measures together, there was comparable outcomes between carotid artery stenting and endarterectomy in the CREST trial. So, to summarize the available data and the guidelines, this is an algorithm for management of extracranial carotid artery stenosis. And it goes as such: if we have a patient coming with carotid stenosis, the first question is going to be, is he symptomatic? Yes. Then do we have a confirmatory imaging with the exact degree of stenosis, like a duplex plus CTA or MRA? Yes. Then we look at the degree of stenosis. If he has a carotid occlusion despite of his symptoms, then he goes on the best medical therapy. Carotid stenosis of less than 50%, we're still in the best medical therapy. On the other hand, symptomatic carotid stenosis more than 70%, then patient has a strong recommendation to go for carotid endarterectomy plus best medical therapy with alternative possibility of carotid stenting. People with moderate carotid stenosis and symptomatic, also with a smaller, with a lesser degree of recommendation, would go for carotid endarterectomy and best medical therapy, especially in the male gender population versus female, or alternatively, carotid artery stenting in high-risk patients. On the other hand, if the patient presents with no symptoms, imaging confirmed carotid stenosis. If a patient, again, has a total carotid occlusion, best medical therapy, less than 60% stenosis and asymptomatic, best medical therapy, carotid stenosis, asymptomatic, more than 60%, then we have to look at other factors. Life expectancy more than 5 years, other imaging indirect parameter that will put the patient on a higher risk to have recurrent neurologic event. Then with that in mind, the patient can be offered carotid endarterectomy plus best medical therapy, and an asymptomatic patient, alternatively, carotid artery stenting with a lower degree of recommendation. So overall, as a clinical guideline, constitute corridors of action, rather specific directives. Physicians remain responsible for adapting any of these guidelines to and recommendation to this particular individual patient. For this patient, whom any events for this particular patient is going to be 100%, not 1, not 2, and not 5%. So we should adapt the guidelines which are only recommendation to that particular individual. And in the case of carotid stenosis, the above is most adequately achieved with proper communication and multidisciplinary approach, likely between the vascular surgeon, interventionalist, neurologist, and the cardiologist of the patient to achieve the best recommendation for that particular patient that will give him the best benefit from the procedure versus a best medical therapy. With that in mind, thank you for your attention. I hope that was clear enough and that the audio and the presentation was actually clear and well received. And we have time for questions or discussion.
Thank you, Dr. Haddad. It was a very wonderful presentation, extremely well structured. It was amazing. And as you mentioned, we have room for questions now. So I would like to ask everyone to type in your questions in the chat box, and I will be reading them to facilitate the process. One of the questions was by Abdelmajid Ibrahim, and he asked, why is it not recommended to receive occlusion in occluded or nearly occluded vessels?
This is a very good question, because in occluded vessels or in near occlusion, we call it also a string sign, whereby there is barely any more circulating lumen in that carotid. Those patients are not prone for embolization anymore. And actually operating on totally occluded vessels carries, and it was done in the literature previously, thrombectomizing and operating on totally occluded carotid. The risk of stroke during that procedure is much more and significantly higher than the natural history of the patient without procedure, especially with best medical therapy. So it's strongly not recommended nowadays, although one would be tempted to operate on totally occluded carotid, except in the case where the patient presents acutely with acute carotid occlusion, mostly within the coming 2 hours and acceptable up to 4 hours after the index event.
Thank you, Dr. Haddad. Concerning Ra'ed, he had a question which was answered in one of the future slides, so this one is clear. Nancy Abu Amoud had a question. It's how do the complications of both procedures, carotid endarterectomy and carotid stenting, differ?
Yeah, the carotid stenting involves crossing with the catheter and sheath and wire the aortic arch of the patients, accessing the common carotid and stationing a sheath or a working channel inside the common carotid artery, possibly the symptomatic artery, and then crossing the stenosis again with the wire and with the filter before even opening the protection device, which is the filter. All that and along all these steps of this procedures carries the risk of embolization and neurologic event, not only from the carotid itself, but also from a calcific diseased arch vessel. And this is why, if you notice during the discussion, I specifically mentioned that elderly people who have in general more tortuosity in their arch, more calcific and diseased arch vessel, do worse with stenting versus endarterectomy. This is one way of looking at it, and this is one way in where early on in the early stages of carotid stenting, people had more neurologic event, whereby when you're doing endarterectomy, you're not really manipulating or crossing the stenosis. You gently dissect the vessel gingerly and then clamp the internal carotid artery. So when you clamp and open the carotid bifurcation, which is the source of the emboli, you are kind of protected. And this is why you may have less incidence of stroke in that regard, and this is the difference. Now, we have to know that recently with the modern carotid artery stenting and with high volume and experienced center, there is an extensive imaging before to make sure that these lesions are amenable with a low risk of carotid artery stenting, and this is the way it should be. In good selection, then you get same result with carotid endarterectomy and with carotid artery stenting. More recently, there are a TCAR, a recent approach, which do the stenting of the carotid without crossing the arch by doing a small cut down on the base of the common carotid artery. And those procedures are showing amazing good results, comparable or even better than the carotid endarterectomy nowadays. So we are going to see a bit of better, like Rolls-Royce outcomes in carotid stenting, I think, in the coming few years.
Wonderful, thank you.
Hope that,
One more question.
yeah.
One more question by Abdelmajid Ibrahim Nabil Al-Jariri. So the completely occluded single carotid artery, how much are the neurological functions decreased? And is there a role for bypass graft in completely occluded vessels?
Okay, so I hope I'm going to be able to answer that because I think part of this question don't have a clear answer. What happened to the neurologic events and the carotid occlusions? Carotid occlusion can be completely asymptomatic, and patient can come with incidentally occluded carotid and having had no experience of neurologic event in their past. But also, patient can have carotid occlusion and during occlusion embolize some of the fresh clot in the middle cerebral artery, and patient can present with really significant dense deficit and massive hemiplegia. So it can be either or and can be in either part of that spectrum. Now, why do not carotid bypass work? Because the internal carotid artery has no branches from the neck all the way up to the siphon, up to the first branch, which is intracranial, which is the ophthalmic artery. So once you have an occlusion in the neck on the internal carotid artery, chances are, and most often, that occlusion continue building up all the way up to the siphon, to the first branch. And that you cannot bypass to that, to the intracranial circulation. There was attempts in a certain period in the early carotid surgery era, maybe around between 30 and 40 years back, there was a big hype about carotid to external carotid to middle cerebral artery bypass across the skull and doing bypasses external carotid to MCA bypasses. Those does not give the impressive result that one was hoping for, and this is procedure that is by and large abandoned in the literature.
Thank you, Dr. Haddad. Anyone has any more questions? Okay, so thank you for this wonderful lecture. It was amazing. And for all those who would like to revisit it, you can find it on our YouTube channel.
Thank you very much. Thank you for having me. Thank you, Francesca, for moderating, and it's good to hear from you as well. Thanks, everyone.